The third topic we will cover is an introduction to mortality and morbidity, otherwise known as M&M conferences. The information in this presentation is largely based on the Guidelines for Trauma Quality Improvement Programs, Geneva World Health Organization, 2009. The core learning objectives of this module are to provide a basic understanding of the following: the role M&M conferences have in improving trauma systems, how M&M conferences can be utilized and improved in all circumstances, including low and middle income countries, identifying, recording, and responding to poor outcomes, and summary and conclusion. The role M&M conferences have in improving trauma systems. Morbidity and mortality conferences, also known as deaths and complication conferences, involve a discussion of deaths and complications that appeared in trauma care in order to look for preventable factors. M&M conferences are performed around the world in many hospitals, almost everywhere where there are formal medical specialty departments and often in smaller hospitals as well. Trauma cases are frequently included in such M&M conferences, especially in hospitals that have surgery departments. The peer review process involved in the M&M conference is the foundation for improvements in medical care through more formal QI programs. Typically, all types of cases are discussed at M&M conferences. Likewise, all deaths, complications, adverse events, and errors should be discussed. To optimize the effectiveness of M&M conferences, the meetings must be viewed not only as discussions of deaths and complications, but as opportunities to identify problems and propose solutions. After the conclusion of the M&M conference, clinicians should move forward and take further action to solve the problems that are identified at the conference. M&M conferences should be held at regularly scheduled times according to the institution's volume of trauma. Hospitals that have higher trauma volumes may have specific M&M conferences on trauma alone, rather than having trauma cases incorporated into the broader departmental M&M conferences. Many hospitals with high trauma volumes hold M&M conferences weekly. However, hospitals with low trauma volumes may have sufficient opportunity to address deaths and complications associated with trauma care on a monthly basis. While the first hour of patient care and trauma has been called the golden hour, the M&M conference has also been dubbed the golden hour of the surgical working week. At this time, you should take a look at Handout 1, Morbidity and Mortality Conference FAQs, and briefly review the handout. Please think about your thoughts or responses to each of the following questions. When should the meetings be held? How long should the meetings last? Who should attend the M&M conference? Who should lead the meeting? What should be discussed? And how should patient care issues identified at the meeting be addressed and fixed? How M&M conferences can be utilized and improved in all circumstances, including in low and middle income countries. M&M conferences are a means to strengthen trauma QI, particularly in low and middle income countries. M&M conferences are already being regularly conducted in many Two major improvements could drastically change this. More attention to detail in terms of procedures for conducting the conference, and more attention to detail in identifying the problems, especially those relating to systems issues. This is done by developing reasonable corrective action plans, following through on implementing these plans, and evaluating whether the corrective action has had its intended consequences. Improving procedures for conducting the M&M conference include more attention to details such as optimizing the length of the M&M meeting, defining who should attend and who should run the meeting, and determining the types of cases that should ultimately be reviewed. Improving identification of problems, especially those relating to systems issues, includes more attention to details such as developing reasonable corrective action plans, following through on implementing these plans, and evaluating whether the corrective action has had its intended consequences. Several structural issues could also increase the effectiveness of M&M conferences. These include ensure availability of adequate support staff for logistics and data management, and assure active participation and buy-in by a wide range of clinicians involved with trauma care. Identifying, recording, and responding to poor outcomes. A separate multidisciplinary Trauma QI committee is an extension of the M&M conference. The Trauma QI committee meeting can either be integrated into the departmental M&M conference format, or at larger hospitals, it can be a freestanding meeting. At larger hospitals, the leader of the Trauma QI process is often designated by the institution as the trauma director and requires adequate administrative support. Trauma program managers and administrative assistants are responsible for logistics, data processing, resource allocation, and communication with the complex array of doctors, nurses, and supportive services that are involved. Active participation and buy-in to the formal QI process is required from the entire trauma and critical care teams, as well as from doctors in other specialties such as anesthesia, orthopedics, emergency medicine, neurosurgery, the blood bank, also known as transfusion services, and radiology. Other important contributors of the QI process are administrative and nursing staff from the pre-hospital arena, the emergency department, intensive care unit, and operating room. Support staff who are essential to the infrastructure of QI include the trauma program manager and trauma registrars, which are those that work with the trauma registry, who are responsible for logistics and data collection. Minutes should be taken at the Trauma QI committee meeting and should reflect the review, discussion, and analysis of the case in question, and should also include the proposed corrective action, if applicable. Information from discussions is best recorded in a standardized form, whether for Trauma QI committee proceedings or for departmental M&M conferences. Such a form can help to make sure that important information is addressed in the peer review process, including discussion of corrective actions. Please reference handout number 2, Sample QI Tracking Form. This Sample QI Tracking Form is also shown on your screen and can be reviewed in further detail. On occasion, the Trauma QI process identifies an unanticipated poor outcome. The goal of formulating corrective actions to improve care and address the poor outcome can be incorporated into an existing meeting. The meeting attendees can comprise a working group to review and discuss the evidence and formulate a protocol that is relevant to the institution's needs. It is also much easier to obtain buy-in from practitioners for protocols if the practitioners have played an active role in developing these protocols. Doctors and/or nursing staff who are skilled facilitators and who encourage constructive discussion and positive interactions, as well as contributions from team members, are essential to make such working groups a success. Summary and conclusion. The peer review process involved in the M&M conference is the foundation for improvements in medical care through more formal QI programs. M&M conferences involve a discussion of deaths and complications that appeared in trauma care in order to look for preventable factors. M&M conferences are a means to strengthen trauma quality improvement. M&M conferences are performed around the world in many hospitals. At this time, we would ask that you break into small groups of 3 to 5 people to identify and discuss possible local examples of preventable factors that an M&M team might need to consider.